Good afternoon, everyone. Myself, Divyadashri Indian. It gives me immense pleasure to warmly welcome you all to today's case presentation session. We are privileged to have with us distinguished faculty members and coordinators who continuously guide and support our students throughout their academic and clinical journey. A very warm welcome to Jemima Ma'am, Internship Program Head, whose valuable guidance and leadership play an important role in the successful implementation of the internship program. I also extend a warm welcome to Om Priya Ma'am, Internship Academic Coordinator, whose constant academic support and coordination help our interns make the most of their clinical learning experience. We are also delighted to welcome our resource person for today's session, Ms. K. Supraja, Assistant Professor in the Department of Optometry, Allied Healthcare Science, Avinashi Lingam Institute for Home Science and Higher Education for Women, Coimbatore. Ma'am brings with her over 13 years of teaching and research experience in optometry and vision science. Along with more than 10 years of clinical experience, she has undergone clinical training at the prestigious Shankaranethalaya High Hospital, Chennai. Her areas of expertise include low vision, community optometry, glaucoma, and optometry-based application development. She has also contributed a chapter on eye in the book Geriatric Care in India: Perspectives and Challenges. She has served as a resource person and delivered plenary and keynote lectures at various prestigious platforms across India. Her professional journey reflects a rich blend of clinical practice, research, education, and community eye health initiatives. It is indeed an honor to have such an accomplished academician and clinician with us today. Now, without further delay, let us begin today's case presentation session. Over to today's presenter, Ms. Padmashree.
Thank you, Divyajashni. Good afternoon, everyone. I'm Padmashree, an intern at Dr. Agarwal's Eye Hospital. Today, I'm going to present a case of third cranial nerve palsy from a clinical and optometric perspective. Coming to the case history, the patient was 54-year-old male and his occupation was driver. The chief complaint was wavy vision for both distance and near, which was presented for 1 day. Regarding his previous ocular history, he was diagnosed with glaucoma 1 year ago, but he was not using any eye drops. There was no history of trauma, spectacle use, or previous ocular surgery. Regarding the general history, the patient was a known diabetic and hypertensive for the past 5 years, and he was not under medication. He was under medication. There was no significant family history, no recent investigation, no current medication, and not aware of allergies. The initial intraocular pressure was 17 and 20 mmHg. Coming to the ocular examination, the distance visual acuity was 6.9 in the right eye, improving to 6.6 with pinhole, and 6.6 in the left eye. Near visual acuity was N6 for both the eyes. The refractive findings were also assessed, and the patient achieved good visual acuity with the appropriate refractive correction. Color vision was also assessed. The initial findings were abnormal, and the response improved with the red filter. Coming to the EOM, there was restriction of adduction in the right eye, while the movements of the left eye were full and normal. On cover testing, the patient showed alternative exotropia at both distance and near. Worth dot test shows alternative suppression. On slit lamp examination, the upper lower lids, conjunctiva, and cornea were normal in both eyes. The pupil were reactive to light, and both lenses were clear. The anterior chamber depth was noted to be shallow. Coming to the fundus examination, the optic disc and posterior segment were assessed in both eyes. The left eye showed a blurry disc margin, while the remaining documented fundus findings were essentially normal. Based on the clinical findings, further investigation were advised, including fundus photo, diplopia charting, and MRI. Fundus photography was performed for both eyes, and the findings were within normal limits. Next, diplopia charting was performed to assess the pattern of ocular deviation in the different gaze position. The important finding here was the difficulty in adduction of the right eye. The pattern was consistent with a medial ductus involvement and supported the presence of medial ductus palsy. At this stage, MRI was still pending. The patient was, based on the clinical findings, the provisional diagnosis included multiple cranial nerve palsy suspect, Webinar, which stands for wall-eyed bilateral internuclear ophthalmoplegia, and congenital color vision deficiency. The patient was advised to obtain immediate physician opinion for strict control of diabetes and hypertension. Neurologist and oculoplasty opinions were also advised for further evaluation and management. On the next day, the patient was reassessed following the retina opinion. On EOM, the right eye showed restricted uniocular movement with a medial rectus palsy, while the left eye showed full and normal uniocular and binocular movements. Perimetry for both eyes was advised, but the patient was not willing to undergo the test. MRI of the brain on orbit was also advised, but at this stage, it was still pending. Based on the clinical reassessment, the diagnosis was made as right third cranial nerve or oculomotor nerve palsy. The patient was prescribed medication along with lubricating eye drops. Urgent neurological opinion was advised, particularly to rule out a space occupying lesion. The patient was reviewed after 1 week. The distance visual acuity was 6 by 12 in the right eye and 6 by 9 in the left eye. Near visual acuity was not examined at this visit. The IOP was 24 in both eyes. MRI of the brain orbits with contrast along with VR venography. The report shows midbrain hemorrhage subacute. Following the MRI findings, further investigation were advised, including gonioscopy and ASOCT. However, the patient was not willing to undergo ASOCT. At this stage, the clinical picture include third cranial nerve palsy, bilateral primary angle closure suspect, midbrain hemorrhage, and bilateral internuclear ophthalmoplegia. YAG-PA was advised for both eyes under GVP. The patient was advised not to dilate, to maintain strict diabetic control, and to obtain neurological review for bilateral internuclear ophthalmoplegia. Alternative spectacle patching was also advised. There were several limitations in this case. Firstly, the patient initially presented with atypical symptoms, which resulted in multiple provisional diagnoses. Secondly, the MRI findings were not available during the initial examination, so the defective neurological cause was not immediately identified. The presence of diabetes and hypertension also complicated the clinical picture. In addition, bilateral internuclear ophthalmoplegia made the diagnosis more challenging. Also, the patient was not willing to undergo certain investigation, particularly perimetry and ASOCT. To conclude, this was an ongoing clinical case because the patient was still under neurological evaluation and treatment, and therefore the final visual and the systemic outcome could not yet be determined. However, this case highlights the importance of early recognition, appropriate referral, and continuous monitoring in the neuro-ophthalmic condition. This case demonstrates the neuro-ophthalmic disorders may not always present with classical signs described in textbooks. In this patient, the absence of ptosis, reactive pupil, and the absence of atypical down and out position made the presentation atypical. Therefore, a stepwise clinical approach with repeated assessment was important in reaching the diagnosis. Correlating the ocular findings with systemic and neurological finding helped improve the diagnostic understanding of this case. Now, moving on to the theoretical part, third cranial nerve palsy is a neurological disorder resulting from damage to oculomotor nerve. It can affect ocular motility, eyelid position, pupillary function, accommodation, etc. The third cranial nerve arises from the oculomotor nuclei and Edinger-Western nucleus, which are located in the midbrain. It contains both somatic motor and parasympathetic fibers. The motor fibers supply the superior rectus, inferior rectus, medial rectus, inferior oblique, and LPS. The parasympathetic fibers supply the sphincter pupillae and ciliary muscles. The main function of the oculomotor nerve are adduction, elevation, depression of the eye, elevation of the upper lid, pupillary constriction. Its causes can be divided into 5 parts: the fascicular, basilar, intracavernous, intraorbital, and pupillomotor portions. Third cranial nerve palsy can be congenital or acquired. Acquired causes include diabetes mellitus, hypertension, aneurysm, tumor, trauma, migraine, and vascular diseases. In this patient, diabetes and hypertension were important systemic risk factors, and the MRI later demonstrated a midbrain hemorrhage. Classically, patient with third cranial nerve palsy may present with ptosis, diplopia, headache, eye pain, blurred vision, pupillary dilatation, and restricted ocular movements. The affected eye typically assumes a down and out position. This happens because the muscle supplied by the third cranial nerve become weak. The lateral rectus and superior rectus act relatively unopposed, pulling the eye outward and downward. Management primarily depends on identifying and treating the underlying cause. Associated systemic conditions such as diabetes and hypertension should be controlled. Diplopia can be managed with measures such as patching, and a regular follow-up is required, and surgical intervention may be considered when necessary. When comparing the theoretical presentation with our patient, there were several similarities. Diabetes and hypertension were present. Ocular movement restriction was present, particularly involving the medial rectus and causing defective adduction. Ocular deviation and abnormal binocular vision with suppression were also present. Finally, neurological evaluation and MRI were required to determine the underlying cause. However, there were also several important differences from the classical presentation. Classically, third nerve palsy may present with ptosis, but ptosis was absent in this patient. Atypical down and out position was also not observed. Classical cases may involve multiple EOM, where this patient predominantly demonstrated medial rectus involvement. Pupils were reactive, so obvious pupillary involvement was not present. Another unusual feature was the patient complained of wavy vision rather than clinical diplopia. The presence of bilateral intraocular ophthalmoplegia further complicated the clinical picture. The MRI identified a midbrain hemorrhage as the underlying neurological finding. Therefore, the diagnosis evolved from multiple cranial palsy suspect to Debino to the right third cranial palsy with associated bilateral internuclear ophthalmoplegia. Finally, coming to the role of the optometrist in this case, our role begins with detailed history and a symptom analysis. We assess visual acuity, refraction, pupil, ocular motility, and binocular vision. In a suspected third nerve palsy, we should also carefully document the pattern of motility restriction and ocular deviation and quantify the deviation wherever possible. Additional optometric assessments such as Prisma cover test and HR can be done. Diplopia assessment, fundus photo, visual field assessment can also be contributory to the evaluation. Most importantly, the optometrist should recognize neurological red flags and refer the patient appropriately to the neurological evaluation and imaging. In this case, repeated assessment and referral were particularly important because the initial presentation was atypical and the diagnosis evolved with further investigation. Thank you for listening. I hope I have covered the case adequately, and I would also request Supraja ma'am to kindly point out anything I have missed so that we can learn from you, ma'am. Thank you.
Thank you, Padmashree. It was very well presented, and you gave all the lacunae of the case that was there, and you also justified what it is actually out there. The actual theoretical knowledge we are studying and how the case is actually present are not always as easier as we are studying. So it will be like combination, and we need to rule out step by step. Nice. So let's have a much more clinical reasoning of every slide. Actually, I want to give some inputs and just want to ask if you are aware of those aspects also. So can we go back to the slide?
I'm sorry to interrupt. Your voice is breaking, ma'am.
So that we can discuss.
Ma'am, whether we are audible? Ma'am, this is Om Priya, and your voice is breaking, ma'am.
Am I audible?
Yes, ma'am. Right now it is clear now, ma'am.
Okay. Just a minute. I'll just check my connection. Was I audible?
In between, ma'am. In between, we lost the connection, and it was like
hear
Breaking.
what I was talking.
If you
I'll just check my connect. Clear now?
Yes, ma'am. Now it is clear, ma'am.
Did you even hear what I said before? I don't know if it was raised. Okay, I'll repeat it again. Padmashree, that was an excellent presentation, and you covered almost all the aspects of your case and also the lacunae of your case. And you also pointed out that the actual cases we see, patients we see, are not always similar to the theory we are studying, right? So whatever you have given as a short note, everything was quite extensive. Okay, thank you. So I just want to add on certain points or certain things, and also reassure if you are knowing all that. Okay, so can we go back to the slides and come one by one so that we can discuss more? Am I
Yes, ma'am.
audible?
Yes, ma'am. Sure. Yes, ma'am.
Yeah. Can you present it? I mean, can you just show your slides, or I'll
Yes,
ask
ma'am.
you a question? So the first slide you had, yeah, from the history. So what do you think was the most important presenting symptom of the patient?
Diplopia, ma'am. But there was no diplopia, but he complained of wavy vision.
Yeah, here the complaint was not diplopia. The very complaint was vague, like it was a wavy vision. Okay, so we have to understand not neuro cases, which in diplopia they might not present because of the presence of suppression. Okay, so okay, so good. And so with regard to the health history, okay, what do you think is the important risk factors for the patient?
Diabetes, hypertension, migraine, maybe, ma'am.
Fine, yeah, correct. So presence of diabetes and hypertension can lead to microvascular abnormalities, which can also affect your supply to the eye. Okay, so what do you think additional history or now palsy? What
Sorry, ma'am. Come back again.
else you should?
Your voice is breaking, ma'am.
What is the additional history you should have taken if
Additional
you
history.
specifically suspect it is a third nerve palsy? You have mentioned, no, it is atypical third nerve
Yes, yes, ma'am.
palsy.
But I'm not
Yeah.
sure what I have missed here.
What? Okay. Let me put the question like this: if the patient is suspected to have a nerve palsy, what is the important question we should be concerned of, or it is very important for us to probe,
Is he
so that
had any neuro conditions
anyone
before?
can neuro conditions before? Okay. Anything else? Can you tell what all are the causes for a third nerve palsy?
It may be congenital or acquired, ma'am. Congenital causes may be trauma or viral infections.
Okay, for adult,
For an
adult.
adult, diabetes, hypertension. That's what I have.
Okay, okay. Those are like my most probably related as microvascular abnormalities. There is
Yes,
something
ma'am.
called compressing lesions. Did you read about that? Compressive lesions.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So, what is that one point which we have to catch, or we should be very informed of if you are seeing some palsy patients. Okay, so what if they complained about head pain? Headache associated with all the signs, pain.
Okay.
So what I wanted to tell is, if they are complaining of headache, and your case is like a acute onset. So headache combined with the acute onset of this baby signs, and you have found out some deviation. Okay, then we should be very careful to understand there might be some compressive lesions. Okay, so they are all life threatening. That's why I wanted to insist, if the patient is complaining of head pain also, if it was documented in the history, then it might be a medical emergency. We need to refer them as soon as possible. Okay.
Okay, ma'am.
So next slide. Anything significant in the refraction you saw?
No, ma'am. It's just a normal diffraction and he's having good vision
Okay.
also.
Fine. Good. So since it's improving with pinko, so your slide on color vision. Yes. So can you tell, is the color vision associated with the person's disorder, or it is separate? Is it associated here?
I think it is not associated. Why? Because it's a congenital condition he's having.
So it looks like a congenital color vision deficiency, and
Yes, ma'am.
moreover, is the pupil involved in this case?
No, ma'am.
What
No.
about the pupillary?
It's
So
normal, ma'am.
also
It's
we have
reacting
to
to light.
note here. Yeah, I saw that pupil is not involved. So if a pupil is spared or pupil is involved, is a very important document we need to check. So if pupil is involved, then there might be some compressive lesions also. If pupil is spared, then we cannot think it is safe, but still they need some neurological opinion. Okay, so if pupil is involved, we must be still more concerned. Okay,
Okay,
fine.
ma'am.
So next. So if it is a cranial nerve, third nerve palsy, then what all muscles are expected to be affected?
Superior rectus, inferior oblique, medial rectus, inferior rectus, LPS also LPS.
LPS, yes. Medial rectus, superior rectus, inferior oblique,
Superior rectus,
LPS,
LPS.
and pupillary involvement might also be there, and they might have, since the supply is also to the ciliary muscles, yes, and sphincter pupillae, they are the parasympathetic part of the cranial nerve 3, so they might also get affected. So among all these innovations, what do you think the patient didn't have in this case
Except
for the
MR,
gradient?
adduction problem, he didn't have any other symptoms, ma'am.
So
He had
what all
only problem at adduction.
So there was no ptosis.
No, ma'am.
Yes, no ptosis, and pupillary involvement was not there. So
Yes, ma'am.
is why the case was termed atypical? Why was the case diagnosed as atypical third nerve palsy?
Evident clinical features not seen, ma'am, especially the down and out position, which is large hypo with
Yes.
large exo.
Okay, fine, very good. And next slide. Okay, regarding the suppression, why did the patient experience suppression in this case, or why suppression was present?
Because of the alternative exotropia, he used to have suppression,
So
ma'am.
because
That's
of
why he
the
had.
presence of diplopia, It was a compensatory phenomenon that suppression was present. So fine, good. Next slide. So find in the slit lamp.
Yes.
Grading was there.
There is no particular grading mentioned, but his angles are shallow, ma'am.
Okay, fine. Next.
Shall I move to the next slide, or you have to tell anything, ma'am?
Medications, right? No anti-glaucoma medication. Next slide. Next slide. Next. Okay, so can you explain the diplopia charting here?
Yes, ma'am. Since he had a difficulty in the adduction in the right side, he can't able to appreciate both the colors in the right side, ma'am. So he see only red color in the right side because of the medial rectus palsy.
Okay. So why do we generally do diplopia charting, and what other tests combined we do along with diplopia charting? Do you think? Am I audible?
Yes, yes, ma'am. Yes, ma'am.
Any other tests they will be doing along with diplopia charting? Is this subjective or objective charting?
Subjective. Subjective one.
Subjective. So then any other test? Any other test to assess the how much the deviation is? We do along with diplopia charting to reconfirm. Do we do anything like that?
Maybe while doing
Good.
the
Someone has answered. Someone has answered his charting. Very good. So yes, we can also do a combined test charting to find out if there is any overaction or underaction of muscle that can be done objectively, right? So as far as this, what is the diagnosis from the diplopia charting?
medial rectus palsy. I mean, limited in adduction.
Adduction. So there is some abnormality in adductions.
Yes.
Okay. Fine. Thank you. Next slide. Next slide. Next. Can we go to the final diagnosis?
Yes, ma'am.
So what is that? Nuclear ophthalmoplegia you have as a provisional diagnosis that has been given.
Ma'am, could you repeat? Your voice is still breaking.
Ophthalmoplegia that you had mentioned.
Yes, ma'am. Yes, ma'am.
Can you tell about that? Yeah. So okay, let's stop with this slide. Okay, fine, good. So what is this internuclear ophthalmoplegia? Can you tell about internuclear ophthalmoplegia that you had mentioned?
Yes, ma'am. Paralysis of intraocular muscles, I think.
Enapa? Intraocular muscle. What muscle? Okay, so where is the origin of this internuclear ophthalmoplegia? The abnormality or the origin of that? No, I just wanted to ask Padmashree if she was completing on internuclear ophthalmoplegia. I asked her the origin of the internuclear ophthalmoplegia. Where is the origin?
Okay.
The disease origin.
Okay. Over to Padmashree.
Yes, ma'am.
Okay, so I'll just try give you an answer. So it is at the level of MLF, medial longitudinal fibers, which is not at the level of midbrain, but it is along the brainstem region. So, can you give me why this case was diagnosed as internuclear ophthalmoplegia? Because the brain hemorrhage seems to be at the midbrain level, but the origin for internuclear ophthalmoplegia is almost brainstem. So I'm trying to gather points why it was diagnosed internuclear ophthalmoplegia. Padmashree?
Yes, ma'am. Maybe the MLF connects one of the side to, I mean, contralateral third cranial nerve, ma'am. I'm not sure. I'm just.
Oh, okay. So even I have this query. That's why I'm asking you. Yeah, the convergence has to be checked. Yes, ma'am. Convergence has to be checked. If in case ophthalmoplegia, the convergence status has to be checked. So was it done?
Not in this case, ma'am.
Okay. So there are certain points we need to check if it was internuclear ophthalmoplegia. How was the horizontal eye movements? Horizontal
As
eye
I,
movements
uh, as I already mentioned, he's having difficulty in abduction case only, ma'am.
in adduction.
Yes, ma'am.
Okay. So probably this they might have to we might have to know about the convergence also in this case. Okay, and if is there any nystagmus present? Because usually horizontal eye movement disorders like internuclear ophthalmoplegia, they might be associated with nystagmus. Then convergence might be affected. Okay, so convergent assessment has needs as a point to confirm if it is internuclear ophthalmoplegia. So I just wanted to know if it was done and that was how it was confirmed. So okay, fine. So uh, that is like a hallmark sign for internuclear ophthalmoplegia, right? So what do you think is the treatment for angle closure?
They recommended for YAG PA, ma'am, but the patient was not willing to do it.
As far as the case is, as you said, the connection between the palsy, like how it is theoretically and how the case was presented, is absolutely different. And with systematic measure, whatever examinations has been done. And one small query I have is regarding to the internuclear ophthalmoplegia, which needs to be still more cleared. So, regarding the convergent aspects, regarding the nystagmus and presence of any brainstem lesions. So, how this is linked is will give you a clear picture of how internuclear ophthalmoplegia was also diagnosed. So, with that, I think I have given some insights. If anybody has any question, can ask me.
Thank you, ma'am. Thank you for sharing the clinical insights. And dear participants, if you have any doubt, kindly post in the chat box. So repeating again, if you have any doubts, kindly post in the chat box or kindly unmute yourself. So, Sharon, are you asking a doubt? Are you trying to ask a doubt?
ஆமா இப்போ இன்னைக்கு ஓபன் போஸ்ட் ஆஃப் ஓபன் ஆயிருக்கு இல்ல பிஜி போட்டீங்களா கொஞ்ச நேரத்துக்கு முன்னாடி அதுல அப்படியே இருங்க.
Sharon, are you trying to ask questions? If not, kindly mute yourself. So there is a question from the participant side, ma'am. Please explain how to assess the third nerve palsy by diplopia charting and documentation.
See the patient comfortably at the 50 centimeter. Ensure the patient is wearing their appropriate refractive correction. Place red filter in the right eye and green filter in the left eye. We have to shine the streak light, retinal streak light from patient's backside. Ask the patient, show the light in 9 gaze position. In each position, ask the person whether they can see one or two images and that too in which color, and document the findings. No? We have to show for all 9 gazes.
So, what are the possible inputs they might give? Vertical, horizontal, crossed. How do you document? Just what are the various ways the images can be seen by them if they have palsy? They can have it either up or down, or sometimes tilted. Okay, so the deviation can be little far or closer. Okay, so the right and left, the red and the green images can be either close on each other, or the gap might exist, or it might be seen in the other directions, or it might be up and down, or it might be tilted, some like torsional. Okay, these might be the recording methods. Okay, so we can document horizontal diplopia and that vertical diplopia, torsional diplopia if present. If there is any oblique kind of reply they give, then they might inform it as torsional. So that is how we document. So it is more of a subjective test. So the objective method is we try to use Hess charting. So we mark it in the Hess chart for right eye and left eye separately. And if the marking comes inward, then there is some underaction of the muscle. If the marking goes outward, then there is some overaction of the muscle. Similarly, one side the eye is muscle is overacting, then the other side the eye will be underacting. So it will be the yoke muscles. You can easily observe the activity of the yoke muscles. If one eye is underacting, the other eye will be overacting. So that is how we confirm, and we just document. And nevertheless, doing diplopia charting or Hess charting, we do not confirm. With that, we don't do anything. We just have a track of how much the diplopia exists, or sometimes post-surgical result, how the diplopia is for a patient, they do it. And with this, we cannot do any treatment. We will track how their diplopia is. Okay, so for a proper management, we still have to measure the diplopia. Okay, these are just investigations. That's it. Thank you.
Thank you, ma'am. Thank you for explaining on the diplopia charting. And participants, do you have any other further doubts? So there is another query as well, ma'am. If patient have red and green color issues, how will do?
So if the one of color vision red difficult to perform the test. Green filter is to dissociate. Okay, so the patient may not able to correctly give a answer for this targets. So they might not be able to correctly answer. So it is difficult to perform S chart or least chart in these patients with red green color defect.
Thank you, ma'am. Thank you. We glad we have had with you. Had a great session with you, ma'am. Thank you for clarifying all the doubts and sharing the clinical inputs and sharing the knowledge. Thank you, ma'am. Thank you so much. So thank you, dear presenter, Ms. Padmashree.
Thank you, ma'am.
Thank you, participants, and thank you, the Kabir and the Dhruv, keeping the Q&A sessions active. And thank you, dear participants, and thank you, dear moderator and the speaker. Thank you all. We'll see you in the next case report presentation. You can also watch this case report presentation in the YouTube as well. So links will be shared in a WhatsApp group. Thank you, participants. Thank you all.